Okay, hello. Today I welcome you all to the second class for infectious disease. So we will start with HIV infection first because this is one of the single most important topic from the infectious disease. As previously I have mentioned that there are certain infectious diseases you should never forget about revising, and HIV is one of them. HIV, Lyme disease, spirochete infections, and along with that, tuberculosis is not really that important, atypical pneumonia, and different types of viral infections, which I will be discussing in our discussion now. So I would request you to provide full attention, and towards the end of my class, I will have a very short question answer session. I hope that you will be participating actively. So, Dr. Kobir, have you gone through the first lecture? Okay, all right, that's good. What about you, Dr. Obijit? Okay, thank you. Infectious disease is actually not that boring, right? It's quite interesting and it's quite doable, I think, from all the systems. Okay. All right, so first topic is HIV seroconversion. So what does seroconversion means? It means the time taken for the body to start producing antibody against HIV antigen. So it's basically the time during which the virus remains latent and then the antibody starts being produced against the HIV infection. And this is the time known as seroconversion. Sero is antibody, conversion is the time taken to produce this antibody or converting into antibody. So HIV seroconversion is symptomatic in 60 to 80% of the patients, and it can, a large population actually might remain asymptomatic during this time. So during seroconversion, what happens? Fever is the commonest manifestation. Apart from that, some pathognomic conditions like maculopapular rash, okay, and diarrhea, sore throat. These are very commonly occurring presentation for acute HIV infection. Mouth ulcer, recurrent mouth ulcer can also be indicative of HIV seroconversion. Diagnosis: during this time, the antibody production has not been completed yet. So antibodies to the HIV may not be present during the seroconversion stage. And the seroconversion typically occurs 3 to 12 weeks after infection. And during this time, so what is the diagnostic modality? We can go for the PCR testing or the P24 antigen testing during this particular period. Which brings us to the next topic, which is the HIV testing. HIV antibody testing, this is the most commonly used and accurate test, and it can be done by two techniques, which is the ELISA and more confirmatory Western blot assay. So in MRCP Part 1 examination, they might replace the word Western to Northern blot assay, okay? Be careful regarding this. Most people develop antibodies to HIV at 4 to 6 weeks, but 99% do that by 3 months because this is the time taken by the body to have HIV seroconversion. P24 antigen test, usually positive from about 1 week to 3. This is not, first of all, done on a routine base. Routine base HIV test is always HIV antibody test. But P24 antigen test is particularly important during the latent period because the antibody has not been fully formed yet. So during that time, like for example, after being infected with HIV and during the seroconversion time to full manifestation of HIV, during this particular time, P24 antigen has an important role for detecting HIV. Now, infectious mononucleosis, this is also known as glandular fever. The term glandular means glands, which is visible in large glands in the neck. So glandular fever is usually caused by the Epstein-Barr virus, also known as the herpes virus HHV4, okay? Pay attention to this because HHV4 is the infectious mononucleosis. Cytomegalovirus HHV8 causes Kaposi sarcoma, okay? I will discuss about this a bit later on. So Epstein-Barr virus is 4, HHV 4, and Kaposi sarcoma is HHV 8. Less frequent causes for the glandular fever are the cytomegalovirus and the human herpes virus type 6. Most common during adolescent and young adult. Back in our microbiology class, we have all known the another nickname for this infectious mononucleosis. I think Dr. Kobir knows about this, as you're recently done, right? So what is it known? It's a quite romantic name. Do you know that? Kissing virus, yes. Because this is commonly spread by the respiratory droplet. All right, and sore throat lymphadenopathy, this is the pathognomic. So these are quite tender lymphadenopathy, particularly including the anterior and the posterior cervical chain. And in case of the tonsillitis, usually the upper anterior cervical chain is involved. All right. Other features are just like any other viral infection. It can cause malaise, anorexia, headache, palatal petechiae. Here, important part is splenomegaly, okay? In 50% case of infectious mononucleosis, patients will be having splenomegaly. And that's why even after being completely cured of infectious mononucleosis, we advise the patient not to be in any vigorous activity or any contact sports after at least a minimum of 8 weeks, because during this time, this heavy contact sports can increase the risk of splenic rupture. All right. Apart from that, I want you to focus on this particular word, that is cold agglutinin. There will be some cold agglutinin induced hemolytic anemia. And this is very important, this characteristic, like in infectious mononucleosis patient, if you prescribe them with amoxicillin or ampicillin like of antibiotic or cell wall acting antibiotic, their symptoms will further worsen, and the maculopapular and the pruritic rash develops, and this occurs because of the idiosyncratic reaction. Okay, so this might be actually a clue to diagnose from the stem. They might give you like fever, sore throat, malaise, all this thing. You're in your head, you're thinking like any viral infection can do this. But in the stem, if it is mentioned like the patient was prescribed with a course of amoxicillin and now he's presented with maculopapular rash, so that is very specific for Epstein-Barr virus or infectious mononucleosis. And symptoms typically resolve after 2 to 4 weeks. Here, important test is the monosport test, also known as the heterophil antibody test. And in the FVC, what happens? There is atypical lymphocytosis. I think it's written here, presence of 50% lymphocyte with at least 10% atypical lymphocyte. This is another feature. Management is basically supportive, including rest during the early stage. During any viral infection, we go for this, like take plenty of rest, because all the viral infection have a predisposition of causing myocarditis, okay? Viral myocarditis, and drinking plenty of water or fluid, because any of the viral infection has the potential of causing disseminated intravascular coagulation or DIC. Thrombotic episodes can be triggered, and simple analgesia for any pain. And this kind of analgesia also has another form of beneficial role, like anti-inflammatories can also reduce inflammation triggered by the viral infection. Here, this information. The UK guideline suggests to avoid playing contact sports for 8 weeks after having glandular fever to reduce the risk of splenic rupture. HIV and opportunistic infection. This is very, very, very important. I cannot stress you how much important this particular group of information is. So first of all, try to know like the CD4 count. This is not for diagnostic purpose. This is for to see the prognosis, because the more the CD4 count goes down, the more chances of patient will be becoming infected with opportunistic infection or neoplastic transformation. So when the CD4 count is less than 200, that's when you're most at risk of having this opportunistic infection. Now, different types of, there are several categories depending on the number of CD4 count. Like for example, if this is within 200 to 500, then you are also at risk of having the opportunistic infection, but in a less severe way. For example, oral candidiasis, okay? This is treatable because you can just give the patient some nystatin oral drop and mouthwash that will also help the patient. Shingles, this is also treatable. You can just prescribe the patient with oral acyclovir, all right? Hairy leukoplakia, This is secondary to Epstein-Barr virus, and unfortunately Kaposi sarcoma is one of the relatively non-treatable condition that can occur even when the CD4 count is not below 200. Okay, in questions, when you're solving the question, if one clue is given like CD4 count is maybe, for example, 150 cells per copies per ml. Okay, so the options are Kaposi sarcoma. You're feeling like this might be a possibility because the CD4 count is less than 200. But usually Kaposi sarcoma is one of the devastating complications related to HIV, which occurs even when the CD4 count is more than 200. Okay, always pay attention to the atypical manifestation. Okay, CD4 count, when this is 100 to 200, you can remember it like CCPP. Okay, CCPP, cryptosporidiasis, which is a protozoal infection. Cerebral toxoplasmosis, we already know about this. Progressive multifocal leukoencephalopathy, which is secondary to the JC virus, which is a type of polyomavirus, and pneumocystis cerevisiae pneumonia. Okay, we have discussed about this back in the respiratory medicine, I think. HIV dementia. Here, why this box is important, you can see in the CD4 count 50 to 100, all sorts of fungal infection will take place. None of these are fungal here. Cryptosporidiasis, cerebral toxoplasmosis, progressive multifocal leukoencephalopathy, viral infection, pneumocystis cerevisiae pneumonia, it's a bacterial infection, and sorry, it's a protozoa or eukaryocyte, right? Some authors also mentioned this as a case of bacteria as well. When the CD4 count is really low, like 50 to 100, that's when the fungal infection will start taking place. For example, aspergillosis, esophageal candidiasis. Oral candidiasis takes place when there is CD4 count 200 to 500. Esophageal candidiasis is really bad. It's very difficult to keep it under control. You have to go for systemic antifungal like amphotericin B infusion. This is esophageal candidiasis, cryptococcal meningitis. So this is very like high mortality in HIV patients. Even after giving systemic antifungal, the chance of recovering is very low, cryptococcal meningitis, and primary CNS lymphoma. Epstein-Barr virus, here you can see Epstein-Barr virus is causing the primary CNS lymphoma when the CD4 count is 50 to 100. Same Epstein-Barr virus will cause oral hairy leukoplakia when the cell count is 200 to 500. Now, what if the cell count is very, very low, like even less than 50? In that case, remember two important infections. One is cytomegalovirus retinitis, and the second one is Mycobacterium avium intracellulare. Okay, cytomegalovirus retinitis affects around 30 to 40% of the patients with CD4 count less than 50 cells per cubic millimeter. We will discuss about each of these opportunistic infection a bit later. Just this one, remember like what are the cell counts and which infections will be predominant. Kaposi sarcoma 200 to 500. Epstein-Barr virus causing oral hairy leukoplakia 200 to 500. Epstein-Barr virus causing primary CNS lymphoma. What's the count? 50 to 100. When it is less than 50, CMV retinitis, Mycobacterium. All the fungal infection 50 to 100. Yes, no shortcut. You just have to like cram this information. HIV diarrhea, important possible causes are cryptosporidium and other protozoal infection, cytomegalovirus, Mycobacterium avium intracellulare, particularly when the CD4 count is less than 50. Giardiasis. Giardiasis actually can take place in any immunocompromised patients. Commonest route is fecal route. Any diarrhea agents will be occurring this fecal route. However, if you found cryptosporidium and cytomegalovirus causing the diarrhea, you have to be very suspicious for whether the person has HIV or any other immunocompromised condition going on or not. Okay, if a patient is receiving chemotherapeutic agent, that person is also in risk of developing this opportunistic infection causing diarrhea in them. So cryptosporidium is the most common infective cause of diarrhea in HIV patient. It's an intracellular protozoa. Incubation period is very short, like 7 days. Presentation can be very variable. Here, diagnostic information is, if you go for the acid-fast stain of the stool, may reveal characteristic red cyst of the cryptosporidium. Treatment is difficult with the mainstay management being supportive therapy. Previously, we usually used to remember it like any protozoal infection, Zox, right? Nitazoxanide. Yes, this was used, but nowadays it has been banned, particularly in the immunocompromised patients, because it has a tendency of causing toxic megacolon in immunocompromised patients. Mycobacterium avium intracellulare, it's atypical mycobacteria seen when the CD4 count is below 50. Typical features: fever, sweat, abdominal pain, and diarrhea. There may be hepatomegaly with deranged liver function test. Diagnosis is usually, it's quite difficult to diagnose, to be honest. We can go for the blood culture and the bone marrow examination. Management is kind of similar to the anti-TB regimen, like rifabutin, ethambutol, and clarithromycin. Kaposi sarcoma, this is caused by human herpes virus 8, and it usually causes characteristic skin lesion. This is purple, papule, or plaque-like lesion on the skin or the mucosa. Mainly, if this is involving the mucosa, it will involve gastrointestinal tract and respiratory tract. Skin lesions can ulcerate later on. Respiratory development or involvement may cause massive hemoptysis and pleural effusion. Important thing to know about Kaposi sarcoma: in HIV patient, if you see any ugly looking ulcer, you should have strong suspicion of Kaposi sarcoma, first of all. Secondly, skin characteristic lesions like purple papular plaques, these are more common rather than mucosal involvement. And if it does cause mucosal involvement, common mucosal involvement is in the form of gastrointestinal tract or respiratory tract. Here you see like treatment, there is very limited treatment option, radiotherapy and resection, and they do have tendencies of recurrence. HIV, biliary and pancreatic disease, very important information lies here. Pancreatitis in the context of HIV infection may be secondary to antiretroviral treatment, especially didanosine. Didanosine is a nucleoside analog reverse transcriptase inhibitor, okay, NRTI. Or the pancreatitis can occur in the background of opportunistic infections such as cytomegalovirus, but 3-star importance on the didanosine or NRTI heart therapy. So Mycobacterium avium complex, I think I've already covered, like these information are just given here. And if the CD4 count is less than 50, then we can go for some prophylactic actions such as clarithromycin can be given. HIV and pregnancy, with increased incidence of HIV infection amongst the heterosexual population, these are like relatively normal. In UK, the prevalence of HIV positive pregnant women is quite high compared to other developing nations, 0.4%. The aim of treating HIV infected pregnant women was the importance. HIV to prevent HIV related complication during pregnancy, at the same time to prevent vertical transmission to the fetus. So factors which reduce vertical transmission is as early as possible, like if a mother is being tested positive for HIV, we should start with a heart treatment, or like basically anti-HIV treatment regimen should be started as soon as possible. And at the same time, mode of delivery is also important. Like imagine, instead of going for the vaginal delivery, you can also reduce the risk of vertical transmission by going for the cesarean section. Breastfeeding. After breastfeeding in an HIV infected mother is discouraged, okay? Bottle feeding is rather than, it's good. Neonatal antiretroviral therapy if the neonate becomes tested positive for the HIV. So screening, any pregnant, in our country, we do not go for the HIV screening, do we? What are the 3 important infections we go for screening in pregnancy? You write down, right, in the ward when a pregnant woman comes to you for the antenatal checkup. You go for the CBC, RBS, serum, urinary, and ultrasound of the whole abdomen, blood grouping, RH typing, right? So for infectious screening, what are the important infectious disease screening in our country?
Ma'am, is it torch?
No, in our
torch
country.
infection?
Do you practice in Bangladesh? Hello?
Yeah, ma'am, is it torch infection? I mean
Yes,
torch.
torch screening is yes. This is the ideal type of screening. Like you should cover all the torch related infectious screening. Dr. Sami, where are you based at?
Ma'am, I'm currently working as a lecturer in one of the private medical college in Sylhet.
Select. Okay, okay. So, have you ever like written any infectious screening for any women during the antenatal checkup?
No, ma'am, I'm working as a lecturer. I haven't done any GP practices yet, so that's why
Okay.
I'm not familiar to. I just wrote them when I was an intern in Jalalabad Ragib Medical College. When I
Okay.
wasn't doing my internship, I so
Mhm.
writing this.
Commonly, because torch screening is not available in all of the centers in Bangladesh, and we have to ensure antenatal checkup even in the remotest area. Okay, like in the primary healthcare setting or the union subcenter, you have to go for this very basic test. So in our country, HIV screening is not really done because HIV is not a Bangladesh is not a HIV prevalent country. India is, however, in India they go for HIV screening as well because there are several areas in India where the HIV prevalence is quite high. Any Indian candidate from here? Dr. Okay, she's probably not joining us. Basically, HBs antigen, okay, hepatitis and syphilis screening. This is also done in our country, right? And if there is available resources, then we go for the anti-HCV testing as well. So basically, hepatitis screening and syphilis screening is done in our country. Ideally, HIV screening should have also been done because we never know whether a person is having HIV or not if we don't go for the testing, right? Simple as that. Antiretroviral therapy. All pregnant women should be offered antiretroviral therapy regardless of whether they were taking it previously or not. Usually, the RCOG recommends that it should be commenced between 28 to 32 weeks of gestation and it should be continued later on. Mode of delivery here, vaginal delivery is recommended if the viral load is less than 50 copies per ml at 36 week. So we in HIV infected women, we go for another testing at 36 week to choose the mode of delivery. If the viral copies are less than 50 per ml, then we allow the vaginal delivery, okay? And otherwise cesarean section is recommended. And this is an important question. I think a lot of the times it will come in MRCP part 1 examination. So before beginning the cesarean section, a zidovudine infusion should be started 4 hours before. This is not given prophylactically. This is given only to mothers who are HIV positive, okay? Neonatal antiretroviral therapy. Zidovudine is usually administered orally to the neonate if the maternal viral load is less than 50 copies per ml. So this is one tablet of zidovudine given to the baby if the viral load is less than 50. Otherwise, we go for the triple antiretroviral therapy. And the therapy should be continued for in the peripartum time, and in the second visit we go for the further testing to see whether the neonate is HIV free or not. Is it clear? Okay. Infant feeding in the UK, all women, I think here there has been some typing mistake. It should be all HIV positive women should be advised not to breastfeed. Okay. So Dr. Kobir, when should we start the zidovudine infusion in HIV positive pregnant mother? No, zidovudine infusion given before cesarean section, 4 hours before the cesarean section. So even if we are going for cesarean section, it doesn't mean that we are going to be able to stop the transplacental transmission because transplacental transmission has already taken place during the pregnancy period, right? So in HIV positive mother, we start with the zidovudine infusion even when we are considering for cesarean section. That's all I was trying to say. Vaginal delivery can be considered when the HIV copies are less than 50. I'm just waiting for the azan to be over, then I'll start again. Okay, so HIV and immunization. So here I think this is a good box. You can just give a read, especially focus on what are the immunization. You cannot go for HIV infected adults. Most of the time, the live attenuated vaccines are not recommended for any immunocompromised patients, okay? So that will include cholera vaccine, influenza intranasal, but here you can see influenza parenteral is given to HIV patients. Poliomyelitis, so oral polio vaccine, you should not be given to HIV infected adults, but parenteral poliomyelitis or parenteral polio vaccine can be given. BCG vaccination, never ever ever in HIV affected individuals, because it will not do any benefit, rather than it can cause the patient to suffer from serious consequences related to tuberculosis infection. It can induce latent TB reactivation. So these are the 4 important vaccines that you should not consider in HIV infected individual: oral polio, intranasal flu vaccine, BCG, and cholera vaccine. HIV and neurocomplication, this is particularly important for the neurology section. So toxoplasmosis and primary CNS lymphoma, sometimes the questions can be quite confusing. And here I think the difference that is given in this particular scenario, this can help you a lot. Like for example, in toxoplasmosis, usually the lesions are multiple. Lymphoma, single lesion. Toxoplasmosis, ring or nodular enhancement. So basically, if we go for a contrast CT scan or contrast MRI, then the lesion will be taking up that contrast, right? If this is homogeneously distributed, then it is more likely to be lymphoma. But if this is like a ring-like pattern or nodular-like enhancement, in that case, this is toxoplasmosis. And if you go for the functional assessment like the SPCT scanning, then toxoplasmosis will be negative. But in case of the lymphoma, the thallium SPCT will be positive. Tuberculosis is quite less common compared to the toxoplasmosis or primary CNS lymphoma. It can present like single enhancing lesion. It's not really that important information. Generalized neurological disease, encephalitis, may be due to cytomegalovirus or the HIV itself. Herpes simplex encephalitis is more common in immunocompetent patients, okay? Herpes simplex encephalitis, what's the important lobe that is affected? Temporal lobe, very good. So herpes simplex can also affect any immunocompetent patients as well, not just only in immunocompromised. But if encephalitis is taking place in the background of HIV patient, you should consider it can be done by the HIV virus itself or the cytomegalovirus infection. If you go for the CT scan, there will be just changes like slight edematous brain, nothing else. Cryptococcus, this is a fungal infection causing meningitis. Most common fungal infection of the CNS. So it can present as like headache, fever, malaise, nausea, vomiting, seizure, focal neurological deficit. So anything that a severe level of meningitis can do. CSF, high opening pressure, India Inctus positive, okay, double highlight this. And CT will cause, in the CT, there will be demonstration of meningeal enhancement and cerebral edema, because meningitis almost invariably can also cause meningoencephalitis. Meningitis is the typical presentation, but may occasionally cause space occupying lesion. This is rare. Now, progressive multifocal leukoencephalopathy. This is, remember, like multiple sclerosis, right? From the neurology, this is white matter demyelinating plaque. If this is taking place in the background of HIV infection, this will have the similar kind of manifestation will take place in the form of progressive multifocal leukoencephalopathy, okay? And this is because of the infection of the oligodendrocyte by the JC virus, which is a type of polymer DNA virus. Symptoms is very much likely the multiple sclerosis kind of symptom. Subacute onset, behavioral changes, any neurological deficit can actually take place. And try to remember, like in case of the, because there is demyelinating type of changes in the brain, there is usually no mass effect. Mass effect will take place when there is like lymphoma, toxoplasmosis, space occupying lesion, right? But in case of demyelinating plaque type of lesion, there is usually no mass effect. AIDS dementia complex, this is caused by the HIV virus itself. It usually takes place in a very advanced case of HIV when the CD4 count is between 50 to, was it 50 to 100 or 100 to 200, I think, right? 100 to 200. HIV dementia, 100 to 200, because all the fungal infections will be taking place when the 50 to 100, right? So whenever you're going through, like different information, try to recapitulate from whatever you have read just 5 minutes before. That way you will be having a more comprehensive idea regarding that disease. Okay. Herpes simplex, there are two major types. One is the herpes simplex type 1 and type 2. Previously, it was known that herpes simplex usually is non-sexual transmission and accounted for oral lesion like cold sore, and HSV type 2 is for the genital herpes. But there is actually nowadays, there is considerable type of overlap. Primarily in our medical practice, we often see like a cold sore in the like herpes labialis, cold sore, gingivostomatitis, okay? And if this is a sexual transmission, then painful genital ulceration. What will be the lymph node be like? Yes, this will cause painful penile ulcer, at the same time painful tender lymphadenopathy. Management is basically acyclovir. If this is cold sore, then we can go for topical acyclovir. Apart from that, oral acyclovir. Okay, herpes simplex encephalitis. Here, give red mark here, temporal lobe involvement is more common. So that's why these kind of patients might be presented with aphasia, which is a focal sign. Feature is like any other encephalitis, it can present as fever, headache, psychiatric symptoms, seizure, vomiting. Focal features are aphasia. Peripheral lesion like cold sore, they usually do not have any relation with the herpes simplex encephalitis. Pathophysiology is herpes simplex type 1 is responsible for 95% of the cases in the adults, typically affects the temporal and the inferior frontal lobes. So in any viral infection, okay, so what will be the CSF like? Protein is raised, opening pressure is raised, usually the clear fluid is usually clear, okay, there is lymphocytosis. And the glucose count is normal or low, but in comparison to the bacterial or the tubercular meningitis, this is usually borderline normal. So PCR we can go for the PCR test as well. CT scan will be showing medial, temporal and inferior frontal changes like petechial hemorrhage. This is important. And MRI is better. EEG pattern is lateralized periodic discharge at 2 hours. Treatment is, will oral acyclovir enough here? No, because it has involved the brain. So we go for the IV acyclovir. So the earlier you detect this case and the earlier you start with the treatment IV acyclovir, the less chance of mortality. H1N1 influenza pandemic. This is swine flu, okay? I think I was studying in class 9 during that time, class 9 or 10, I don't know. I forgot. That time we were so happy, like we had the misconception like only people who consume pork will be having this kind of condition. But later on, actually we didn't have much idea about the infectious disease back then. So later on, after studying for a while, I was able to understand that actually, even though this was originally from the swines that were affected and people who used to consume pork, but after a certain period of time, there is people-to-people transmission through the respiratory droplet. So basically, if a person is affected with this kind of swine flu, it does not necessarily mean that the patient consumes pork, because that similar thing happened in COVID-19, right? When it originated in Wuhan, infected bat, after consuming infected bat, this started the transmission. But after a while, it became person-to-person transmission rather than source-to-person transmission. This is a common characteristic feature of any pandemic causing viral infection. Okay, so just like COVID-19, all this swine flu, avian flu, they do have more propensity of causing more damage in immunocompromised patients, like any patients with comorbidities, pregnant women, young children under 5 years of age. Features are, I think you guys already know, like what are the flu-like episode will present like? Treatment here, two main treatments are currently available. One is oseltamivir and zanamivir. Oseltamivir is an oral medication. Zanamivir is an inhaled medication. Both of these are neuraminidase inhibitor, and common side effect as you're taking this medication through orally, so oral or GI upsets will be taking place commonly. And as you're taking the zanamivir nasally, so it will cause bronchospasm in this, especially in the asthmatics. This is a 5-star important topic here. As you can see, all these 4 lines are very, very important. Malignancies associated with Epstein-Barr virus infection. Burkitt's lymphoma, which is commonly predominant in which area? Africa. Okay. Hodgkin's lymphoma, nasopharyngeal carcinoma, and HIV-associated central nervous system lymphoma or primary CNS lymphoma. A non-malignant condition, oral hairy leukoplakia, is also associated with Epstein-Barr virus infection. What's the CD4 count? 200 to 500, right? Good. Hepatitis E. This is an RNA virus spread by the fecal-oral route. Here, important information is it carries a significant mortality in the pregnancy. Does hepatitis A have chronic carrier state? Hepatitis A? Yes, good. A and E, no chronic infection. B and C can cause chronic carrier state. Is there any vaccine against hepatitis A? Yes. Who are commonly given this vaccine? Travelers, okay? In our country, in ICDRB, there is a travelers clinic. It's usually, I used to believe that this is not present in Bangladesh, but I once went to the travel clinic and I found out that actually they do give this vaccine related to hepatitis A. Okay. Cytomegalovirus is one of the herpes viruses. It is thought that 50% of the people have already been exposed to cytomegalovirus, although it's a disease of the immunocompromised patients, okay? So mainly this is seen in HIV affected individuals or patients who have received some form of organ transplant. Pathophysiology, infected cells have owl's eye appearance. What's an owl's eye appearance? Basically, intranuclear inclusion body will push the nucleus and thereby causing owl's eye-like appearance. Patterns of the disease, congenital cytomegalovirus infection. So if the mother is infected with cytomegalovirus, there is an increased propensity of the child to be infected with cytomegalovirus as well. And during the intrauterine, it can cause any, like torch infection during maternal, pregnancy. They tend to cause microencephalopathy, microencephaly, mental retardation, delayed puberty, or it can also cause like hepatosplenomegaly, hearing difficulty, cataract. All these were very common, but you should try to pick up the characteristic finding, like, okay, this infection has this characteristic or common feature that will differentiate from other infection. In cytomegalovirus, this is blueberry muffin, okay? This is the characteristic lesion. Blueberry muffin, which is a pinpoint petechial blueberry muffin skin lesion. CMV mononucleus is okay, fine. In the CMV retinitis, CD4 count is less than 50. It can cause visual impairment, blurred vision. Fundoscopy shows retinal hemorrhage and necrosis, often called pizza retina. Here, IV ganicyclovir is the treatment of choice. Cytomegalovirus encephalopathy, this is also seen in patients with HIV who have low CD4 count, but exact CD4 count is not really given, okay? Cytomegalovirus can also cause colitis, which is the most important infective cause for causing diarrhea in HIV individual. Yes, go on. Cryptosporidiasis, which is a protozoal infection, okay. Apart from cryptosporidiasis and cytomegalovirus, any other infective causes you can think of? Mycobacterium avium intracellularly. Yes, very good. Okay, so dengue fever, I think just give it a read. We all know about dengue more than the information that is provided in the book. Chikungunya, this actually originated in Africa. This is originated in Africa, Asia, and Indian subcontinent. My own mother was actually affected by chikungunya when it first became prevalent in Bangladesh. I think during that time, Bangladesh had like an endemic, right? 2017 or something like that. During that time, yeah, it started quite like we thought that this was a case of gout, but then after like in gouty attack, fever is a rare presentation, okay, and usually like the monoarticular joint that is affected, like the ball of the great toe, right, that is the first joint that is affected, and from first episode to the second episode there is a period of remission. But in my mother's case, what took place is like her ball of the great toe was first involved, and then all of her, it gradually became spread up in whole of her body, you know, elbow joint, knee joint, hip joint, all of these are aching. We couldn't even like get her out of the car and, you know, move her to the elevator because it was very painful condition that time. And there is associated high grade fever. So joint pain, high grade fever, very much suggestive of chikungunya. Measles, okay, for measles there is some important information like the period of infectivity. Okay, so that starts from the prodromal illness until 4 days after the rash starts. Okay, but in case of chickenpox, we have to wait until the skin lesions become crusted. Okay, during that time you should not be in contact with any chickenpox patients. So measles is infective from the prodrome until 4 days after the rash starts. This is an RNA paramyxovirus and spreads by the droplets. Measles is common among the school children. Koplik spot, okay, this is a pathognomic feature for measles. Apart from that, fever, conjunctivitis or red eye, and rash, which starts behind the ears first and then gradually spreads to the whole body. Complication, important complication, this one. This can come in the part 1 examination, like childhood episode of measles, and then 5 to 10 years later the patient is having focal neurological deficit, either in the form of seizure, confusion, loss of consciousness, weakness. Okay, so subacute sclerosing panencephalitis. Wanted to mention one thing. Okay, I'll get back to this later on. Management is, if a child is not immunized against measles and comes into contact with measles, then MMR vaccine should be offered as soon as possible, and this should be given within 72 hours of the contact. Okay, in our country we go for, in the EPI schedule, MMR vaccine is routinely given. In UK this is not a prevalent condition, that's why they do not go for routine MMR vaccine. But if there is an outbreak in a school and other like maybe imagine one school kid is affected with measles, okay, and the teacher and the students, they have been in contact with that particular student. So what happens is like they, first of all, they will close the class, they will notify the Public Health England, and community nurses from the Public Health England will arrive at that place, and they will be in touch with people who have been in contact with the affected kid, and that time they will offer this MMR vaccine. Okay, and they will do it so rapidly, and the contact tracing is done very rapidly. These are really impressive aspects of NHS that I highly applaud. Okay, Zika virus. Okay, Zika virus, not really much information needed. Just remember, this is a mosquito-borne infection. A lot of studies are going under development for Zika virus, because previously it was thought that mosquito-borne infection, but nowadays it also has been postulated that this is related to sexual transmission as well. How, that is a mystery. But this is this is one of those infectious agent that is under investigation. So we don't know much about this. It originated, first it was isolated from a monkey in the Zika forest in Uganda. Transmission, so usually the bite of an infected Aedes mosquito, but sexual transmission has already been reported. Manifestation is just like the dengue, chikungunya, all this type of, but serious complication are Guillain-Barré syndrome. Okay, another important organism responsible for Guillain-Barré syndrome, which one is that? Campylobacter jejuni. Very good. What does it cause? Bloody diarrhea, right? What's the treatment for Campylobacter jejuni? Clarithromycin. Very good. Okay, so all right. advice for the traveler, just give it a read. Okay, antibiotics, mechanism of action. First of all, I think this is a good enough classification. You don't have to, like, these are quite complicated. These are mnemonics here. You can maybe cram them. But good thing is this is more common for residency exams, okay? These kind of questions will come in residency exam or sometimes even FCPS exam. But luckily for MRCP Part 1 examination, not really these are that important. But do go through this classification, like cell wall acting antibiotics are penicillin, cephalosporin. What these do, they will be interrupting the peptidoglycan cross-linking, okay? But peptidoglycan synthesis is inhibited by vancomycin. Protein synthesis inhibitor, you can remember it like AMTC, aminoglycoside, macrolides, tetracycline, chloramphenicol, AMTC. And among that, aminoglycoside and tetracycline will act on the 30S subunit. And the rest of the other antibiotics will work on the 50S ribosomal subunit. Inhibits the DNA synthesis are quinolone, basically ciprofloxacin, metronidazole, sulfonamide, and trimethoprim. Here it will ciprofloxacin inhibits the DNA synthesis, metronidazole causes damage to the DNA, sulfonamide and trimethoprim interrupts with the folic acid synthesis. Yes, antifolate medication. And inhibits the RNA synthesis is RNA, R is for R, that is rifampicin. Okay, again the virulence factor, okay, maybe 1-star important topic. Just maybe give it a read. And important one is remember about the M protein, which is the virulence factor for Streptococcus pyogenes. Bacteriophage, this is important for Corynebacterium diphtheria and Bacillus anthracis. Spore forming, this is the most important one. Clostridium perfringens and Clostridium tetani. Among all these virulence factor, put emphasis on the M protein, bacteriophage and spore forming, okay? Antibiotic guideline, all I can say is it's much more easier if you read the respective disease first, okay? That way you'll be able to remember more. For example, I will go through this here. Genital infection, gonorrhea treatment, ceftriaxone, along with that azithromycin. Why? Coexistent chlamydia infection. Chlamydia treatment, doxycycline or azithromycin. PID, ciprometro combination, okay? Syphilis, penicillin. Bacterial vaginosis, metronidazole, okay? So just remember like one important word or one important antibiotic, you'll be good to go. Most of the gastrointestinal infection, which antibiotic we give? Either ciprometro or combination of these, right? Campylobacter is the only exception where we go for the clarithromycin. Clostridium difficile, metro, because Clostridium difficile takes place in the background of cephalosporin, clarithromycin, clindamycin, all this type of broad spectrum antibiotic. Okay, similar thing here in the skin infection. Most of the time skin infection is caused by the Streptococcus or the Staphylococcus aureus. So treatment is flucloxacillin. Okay, except for one condition, if there is animal or human bite, we go for coamoxiclav in the first place. Urinary tract infection, first line antibiotic, trimethoprim or nitrofurantoin. Lyme disease treatment, doxycycline. Yes, very good. Yeah, I know that when I ask randomly, it becomes a bit difficult to answer. But these are just give it a read. You'll find it's quite easy, not that difficult. Bacteriostatic and bactericidal. Bacteriostatic, you can remember it like CMTTS. Okay, chloramphenicol, macrolide, tetracycline, trimethoprim, and sulfonamide. All these are bacteriostatic, and apart from that, most of these are bactericidal. This is also 1-star important topic. Mechanism of action, I have already discussed about this. Cephalosporin. Now, from the individual antibiotic, I think it's important to know about the side effects and the indication. Like for example, in tetracycline, The indications you see, sorry. For tetracycline, indications are in acne, tetracycline, minocycline, these are commonly given. Apart from them, Lyme disease, which one? Doxycycline is given, right? Chlamydia, which one? Doxycycline is given. Mycoplasma pneumoniae. Atypical pneumonia, mycoplasma pneumoniae, we give doxycycline as well. Sometimes clarithromycin plus minus. So adverse effects are discoloration of the teeth and photosensitivity. Trimethoprim, this is trimethoprim. It is most likely used in the management of urinary tract infection, okay? And adverse effects are myelosuppression and transient rise in the creatinine. Just go through the adverse effect once. Vancomycin, mainly it is used in resistant infections, hospital acquired infection like MRSA, VRSA. Actually in VRSA, this is the vancomycin resistant. In that case, we go for the linezolid, okay? So adverse effects are nephrotoxicity, ototoxicity, red man syndrome. And this takes place after rapid infusion of the vancomycin. Linezolid is used in the MRSA, VRSA and GISA. Adverse effect is thrombocytopenia. This one is important. Monoamine oxidase inhibitor. You should not be using MAO inhibitor along with linezolid. So avoid tyramine containing food. In the antiviral agents, okay, just go through the indication and adverse effects, okay? Like for example, acyclovir, it is used in herpes simplex or varicella zoster. It can cause crystalline nephropathy. Ganicyclovir, this is used in cytomegalovirus infection. It can cause myelosuppression. Ribavirin, this is used in chronic hepatitis C, respiratory syncytial virus. It can cause hemolytic anemia. This is important, okay? Give it a 2-star. Amantadine, apart from influenza, this is also used in Parkinson disease. It can cause confusion, ataxia, and slurred speech. Oseltamivir, we have already discussed in which condition we go for this? Influenza, right? Okay, oseltamivir can cause side effects. Yes, GI upset because it's an oral medication. Foscarnet, this is used in cytomegalovirus infection, and if HSV is not responding to acyclovir, we can go for the foscarnet as well. It usually causes hypocalcemia, okay? Hypocalcemia, 2-star. Alpha interferon, this is actually 4-star topic, okay? Because alpha interferon not only is used in chronic hepatitis B or C infection, it can also be used in hairy cell leukemia, and it can cause flu-like symptom, depression, anorexia, myelosuppression. Cidofovir, okay, it is used in cidofovir or ganicyclovir, these are used in cytomegalovirus retinitis. In HIV, it can also cause nephrotoxicity. Now, antiretroviral agent used in HIV, we will start from here. So basically the groups are, first of all, early inhibitor, which acts on the CCRF receptor antagonist. Here the examples are maraviroc and efoviotide. Nucleoside analog reverse transcriptase inhibitor, or the NRTI. Basically for antiretroviral therapy, 3 main groups of treatments are NRTI, which is the nucleoside analog reverse transcriptase inhibitor, and NNRTI, nucleoside, non-nucleoside, right? Yeah. NNRTI is non-nucleoside analog reverse transcriptase inhibitor, and the other one is protease inhibitor, PI. And apart from this, nowadays early inhibitors have been introduced, and there is another newer medication known as integrase inhibitor. So first of all, know the classification like these 5 groups, then try to focus on the example. Like in the NRTI, there is lamivudine, zidovudine, didanosine, okay? In the NNRTI, there is usually nevirapine, efavirenz, just remember nevirapine, that's fine. And protease inhibitor, it's navir. For example, indinavir, ritonavir, squanavir, so anything with navir. And here important complication is related to the NRTI, which is the lamivudine, zidovudine, didanosine. One of the important complication is pancreatitis, okay? And after zidovudine infusion, there is reported cases of black nail, anemia, myopathy. It can also cause peripheral neuropathy as well. Protease inhibitor side effects are very important. So among all the groups, NRTI and protease inhibitor side effects, these are mostly important. So NRTI, pancreatitis, protease inhibitor, remember diabetes and lipodystrophy. Diabetes, hyperlipidemia, buffalo hump, central obesity, P450 enzyme inhibitor, okay? Related to the, if a stem comes, like after a patient has been diagnosed with HIV and he has started with heart medication, now the patient is presented with acute abdominal pain and recurrent episodes of vomiting, nausea, okay? And this pain goes to the back. So which one you're thinking? Pancreatitis, and the causative didanosine or any NRTIs, okay? Now, if a question comes like there is patient has presented with emaciated body and like, how do I say lipodystrophy? Like for example, asymmetrical limb swelling, okay? So this is known as lipodystrophy. This will come in the part 1 examination sometimes. What happens in the, there is fat redistribution, okay? And it is one of the common side effects related to the heart therapy. Fat redistribution means like in our cheek, there is more fat deposition normally, right? In our arms, in our buttocks or abdomen, in the thigh, there are more adipose tissue. But during the, like dystrophy, due to the lipid dystrophy or redistribution, the fat from the arms will come to the forearm and the arm will becoming thinning. Face will seem like very emaciated, very skinny. And rather than that, the fat will come down towards the neck. This is known as the fat redistribution, and it can typically present with protease inhibitor. Okay. In the antifungal agents, most of the antifungal agents are potent P450 enzyme inhibitor, okay? So amphotericin B is the only antifungal that is used in systemic infection. Other than that, all of these are antifungal in either topical preparation or oral medication, not in parenteral medication. And I think just go through the side effects one time. This is like not really that important, maybe one star important topic. Okay, post-exposure profile exists. Hepatitis A, which I previously mentioned, like there is vaccine available. Human normal immunoglobulin, HNIG, or hepatitis A vaccine may be used depending on the clinical situation. Most likely, if there is more chances of like food poisoning in those areas, we can go for, like for example, UK people, if they want to come to Bangladesh, India, and they want to try the local cuisines, they can get this vaccine prior to the travel. Hepatitis B. Now here it's quite interesting, like if a person has been previously vaccinated, okay, previously been vaccinated with hepatitis B, but now there is a needle stick injury from an hepatitis B infected patient. In that case, we already know the person's vaccine status, right? So in that case, only active vaccination is enough. But if the patient, if the person has not, we don't know the immunization status of the person, or they haven't completed the dose of the vaccine for hepatitis. In that case, we have to go for simultaneous active and passive immunization. That's the basic concept. For unknown source, similarly, like if the immunization status we know, then just one booster dose vaccine is enough. But if we don't know the vaccine status of the affected individual, then we go for the active and passive immunization both. Hepatitis C, is there any vaccine available? No. So that's why after having, imagine like you are drawing a blood from hepatitis C positive patient, and now you have been, have the needle stick injury. In that case, you have to go for monthly PCR to detect the viral load. And if there is any amount of seroconversion, no matter low or high seroconversion, you should be started with treatment, okay? Just straight cut treatment to prevent the progression, like interferon plus minus ribavirin. HIV, combination of antiretroviral. There is also no vaccine against HIV as of yet. So combination of oral antiretrovirals are given to any patient as soon as possible within 1 to 2 hours, but within 72 hours there is a window period. For example, a person who has had sex with HIV infected individual, in that case we already know that he has sex with HIV positive patient without any protection, or maybe with protection but he has doubts. In that case we can go for the post exposure prophylaxis within 72 hours following exposure, okay? And after giving this antiretroviral, we go for the serological testing at 12 weeks, okay? And if this is started as soon as possible within the contact period, then more chances of reducing the transmission. Yes, varicella zoster virus, this is basically routinely given to in a patient who has never been like pregnant women or immunocompromised. They will be given routinely varicella zoster. Now, risk of single needle stick injury, you can remember it like 0.3, sorry, 0.33 and 30%, okay? Chances of HIV is 0.3, chances of HCV is 3%, and chances of HBV is 30%. Okay, vaccination, just give it a read, like live attenuated vaccine, which are those live attenuated vaccine. Important one is here, the fragment or complex vaccines like diphtheria, pertussis, hepatitis B, meningococcus, pneumococcus, and haemophilus. All these are fragment vaccines. And among these, hepatitis B, meningococcus, pneumococcus, and haemophilus, these are conjugate vaccine, okay? Conjugate vaccine is a particular type that links the poorly immunogenic bacterial polysaccharide outer coats to the proteins to make them more immunogenic. So we take some parts of the immunogenic portion of that particular bacteria, we attach it to a special protein which will trigger more immunogenic reaction in the person who's receiving that vaccine. This is known as the conjugate vaccine. BCG vaccine, in our country, we routinely administer BCG vaccine. In UK, they do not routinely give BCG vaccine. And especially this is considered when the like if the baby is born to immigrant family, or if this is a third generation immigrant baby, then there is no need for going that, because the second generation has been already living in the UK, and we assume that the person has been already vaccinated. But if this is a second generation immigrant baby, or the mother and father is proven to be just traveling outside the UK, in that case we can go for the BCG vaccination as early as possible, usually within 16 years. But BCG vaccine is never to be given in any person who is more than 35 years, because there is no added benefit then. And apart from that, like healthcare worker, prison staff, and people who are caring for the elderly in the nursing home, and homeless people, they can be given BCG vaccination, because tuberculosis is more predominant in those particular groups. This is a live attenuated vaccine, and administration, we already know this is given intradermally in the lateral outer aspect of the arm. And if we are going for the BCG, and there should be a minimum of 4-week interval of going for another live vaccine, okay? Contraindication, if you have had a BCG vaccination previously, if you have already been affected with tuberculosis, if we are dealing with pregnancy or HIV, and if the MT test already came back positive, in that case, there is no role of BCG vaccination. And in HIV and pregnancy, there is chances of causing harm more, because these are immunocompromised individuals, so no need to go for BCG vaccination. What are the vaccines that are contraindicated in HIV affected individuals? Yes? Nasal, yes. Oral polio, yes, very good. Okay, chicken pox, this is caused by the primary infection with varicella zoster virus. Shingles is reactivation of dormant virus in the dorsal root ganglion. Chicken pox is highly infectious, spread via the respiratory route, can be caught from someone with shingles. Infectivity is 4 days before the rash and 5 days after the rash. Okay, but because during that time, within 5 days, the lesions are usually crusted. Incubation period 10 to 21 days. In case of measles, what was the infectivity period? Starting from prodrome to 4 days after the rash appears. And in case of chickenpox, this is 4 days before the rash appears and 5 days after the rash appears. Clinical features: fever, itchy rash starting on the head or trunk before spreading. I think everybody in Bangladesh have been affected with chickenpox, right? Back in childhood. Because I remember like I still have the like some marks in my lower eyebrow. I tried to hide it with makeup, but I think every child in Bangladesh have been once at least, affected with chickenpox. Unfortunately, my father, he never had chickenpox, and he was first having chickenpox ever since he came in contact with us. So my mother was the only person who didn't have chickenpox that time. In adults, it's quite severe, because it can commonly involve the cornea, and it's a common cause of blindness. Management is supportive: keep cool, trim nails, calamine lotion. There are lots of superstition in our country in terms of treating chickenpox. I think I remember when I think I was in first or second grade when I had the chickenpox. My mother used to like keep some herbal, what was the English for tulsi? Basically, she used to like soak this in the water, and then she would, like put it in front of the door, because if it's your own kid, you don't want to take any chances. Okay, that's the thing. So, and also she I don't know like if it is also acceptable in other superstition in other culture, but like taking protein during chicken pox, they usually do not go for that. Okay, like they usually fishes like chicken, red meat, these are restricted. I don't know what's the reason. There is no scientific explanation behind this. So a common complication is secondary bacterial infection of the lesion. Rare complications can be pneumonia, encephalitis, disseminated hemorrhagic chickenpox, arthritis, nephritis, and pancreatitis. Chickenpox exposure in pregnancy. I think give a read to the fetal varicella syndrome, which is also known as the FVS. So this is risk of fetal varicella syndrome following maternal varicella exposure is around only 1%, and if occurs before 20 weeks of gestation. Studies have shown a very small number of cases occurring between 20 to 28 weeks, but after 28 weeks, usually the varicella, fetal varicella syndrome never takes place, okay? So if a woman in her late second to third trimester is exposed to a chickenpox baby, then she will not probably have this because the antibodies have already been formed. But if she is exposed 20 weeks before, like in her first trimester, then the antibodies have not been formed yet, because the maternal circulation in that time, the placenta is already circulating, but this is not sufficient amount of antibody that is produced in the fetal body, okay? So that's why the fetal varicella syndrome is more severe if this is first trimester. Features of fetal varicella syndrome: skin scarring, eye defects, microphthalmia, limb hypoplasia, microcephaly, and learning disabilities can take place in fetal varicella syndrome. Other risks to the fetus: shingles and severe neonatal varicella. Okay, fine. Management is of chickenpox exposure. This is important. If there is any doubt about the mother previously having chickenpox, maternal blood should be checked for the varicella antibody. First of all, the mother has had never been, like chickenpox in her early time. So in that case, you go for the routine testing for varicella antibody as soon as she becomes pregnant. If the pregnant woman is not immune to the varicella, she should be given varicella zoster immunoglobulin as soon as possible. You see, if a woman has never had chickenpox before and she becomes pregnant, so in the first trimester, you should definitely check for the varicella antibody and offer her the vaccine. And oral acyclovir should be given if pregnant women with chickenpox presence within 24 hours of onset of the rash. Usually we do not treat chickenpox, do we? There is no need to treat the chickenpox, but during pregnancy, within first 24 hours of appearance of rash, we go for oral acyclovir. In normal patient, not really, because the body's antibody is sufficient enough to fight against the varicella zoster virus. Okay, but in case of pregnancy, antibody, this is already an immune suppressant condition. That's why we try to give for the antiviral medication that time, so that she does not suffer from any complication like fetal varicella syndrome. Now, I think this is malpractice. There is no indication for acyclovir. Okay, rabies. Okay, what's the rabies vaccination strategy? Like, have you ever had any rabies vaccination before? So imagine you just had a dog bite. In that case, what would you do as a doctor? First thing first, try to wash off the wound with what type of soap? Bangla pocha saban. Yes, alkaline soap. And under running water. Okay, try to reduce the viral load from the contact area. Okay, after that, what will you do? Active and passive immunization. Okay, because rabies related mortality is very high, so you should go for active and passive immunization. In which arm? In one arm, if you go for the active vaccination, try to go for passive immunization in the opposite arm. Okay, and then the schedule is usually 0, 3, 7, 14, 28. 28 days, I think. 0, 3, 7, 14, and 28 days. But if you already been previously, given vaccine, in that case, after that dog bite, just wash off that area, and 2 booster vaccine is enough. No need to go for passive immunization. Okay, ORF is not just one star topic. This is found in the sheep handler, sheep or goat handler. So this is more common among the shepherds. It's caused by parapox virus, and ORF lesion kind of looks like very much like a warty and flat topped type of lesion, scabby lesion around the mouth and the nose. Erythema infectious or parvovirus B19. Important information. Try to write this down or maybe use a marker. First of all, parvovirus B19, this is a DNA virus, okay? And most common presenting symptom is slap-cheek syndrome, okay? And illness is slap-cheek syndrome, let's see. After this rash appears, okay, the child is no more infective. So if you see slap-cheek syndrome, no need to be afraid, because once the rash is already developed, the child is no more infectious to others. Here, one of the important complication is aplastic crisis, which is commonly seen in sickle cell anemia or any other chronic hemolytic anemia like hereditary spherocytosis, okay? So, it can cause aplastic crisis. These are the important information. Classification of bacteria, I think just one star topic, but this particular portion, like the gram-positive cocci, staphylococci and streptococci, gram-negative cocci is the Neisseria meningitis and Neisseria gonorrhea, as well as Moraxella. And for in terms of the gram-positive rod or the bacilli, remember the mnemonic ABCDL. A is for actinomyces, B is for Bacillus anthracis, C is for Clostridium, D is for diphtheria, L is for Listeria monocytogenes. Remaining bacteria are most likely gram-negative rod, and there is no other shortcut. I think this is a good summary. Yeah, go to staphylococci now. So staphylococci infection, which is a normal commensal, is staphylococcus normal commensal in the skin? Streptococcus normal commensal in which area? Tooth, nose, pharynx, oropharynx, in this area. Staphylococcus can be also a normal commensal in skin particularly. That's why most of the skin infection, after there is some form of breach, like after wound or any type of like maybe an ulcer or something, the most common infection is Staphylococcus aureus, right? So first of all, this is a gram-positive cocci. It's a facultative anaerobe. So this has mixed property of aerobic and anaerobic properties, produces catalase enzyme. Two main types of staphylococci you need to know about are Staphylococcus aureus and the other one is epidermidis. Aureus is coagulase positive and epidermidis is coagulase negative. This is not really important. Important is Staphylococcus aureus causes skin infection like cellulitis, abscess, osteomyelitis and toxic shock syndrome. This is the exotoxin mediated infection. And Staphylococcus epidermidis on the other hand colonizes on the artificial mean, for example CV line and prosthetic valves or infective endocarditis. This is common organism. So MRSA, this is basically a hospital acquired infection and any patient, inpatient particularly, are at risk of MRSA, and that's why MRSA screening is very important, particularly in the UK. As soon as a person has been diagnosed with MRSA, they usually take the person to a side room, which is also known as isolation room, because it's a very rapidly spreading infection. So from the infected patient, it can transmit the other patients as well, and it can become like epidemic. That's why they take the MRSA infected patient to a side room or isolation room. So how can we screen for the MRSA? The normal locations are, we can take the nasal swab, we can take the wound swab, or if there is any skin swab present, like if there is some like bed sore, right, in stroke patient, you can take the swab from there as well. And microbiology form must be labeled as MRSA screen. Suppression of MRSA from a carrier once identified, that is, we go for the bactrosin ointment or mupiricin in the nasal area, and in the skin chlorhexidine solution. For MRSA treatment, these are commonly used antibiotic, vancomycin, teicoplanin and linezolid. I think that's all you need to know from MRSA. Staphylococcus toxic shock syndrome. I will give you a picture or a scenario. So a young female presented to the emergency department with high-grade fever, and you can notice there is some discoamating lesion in her palms and sole particularly, and her blood pressure is 90/60. And at this moment, which condition you're thinking? Why? Because it's the next topic we are discussing. No, because discoamatic plaque, this is a very characteristic feature of toxic shock syndrome. This is not related to the Staphylococcus aureus, rather this is related to the toxin that is released from the Staphylococcus aureus, okay? This is a toxin mediated, which is why in case of the Staphylococcus toxic shock syndrome, there is no role of antibiotic. So basically high-grade fever, hypotension, diffuse erythematous rash, discoloration of the rash, especially of the palms and sole, and involvement of major organs like gastrointestinal organ like diarrhea, vomiting, mucous membrane erythema, renal failure, hepatitis, thrombocytopenia, CNS involvement, these can also occur. Important one is you can obviously see discoloration of the rash, particularly the palms and soles. From the sepsis, I will be talking about the sepsis 6 bundle. You don't need to go for like these criteria. You don't have to remember it by heart. Just remember the red flag criteria. Go through this once. You don't have to go through the amber flag criteria. This is for the NHS who are already working in the NHS. It will be a bit helpful. But red flag criteria, this is more important. Try to remember it. So what are the sepsis 6 bundle? In any patients, we are suspecting this person is having sepsis or septicemia. In that case, 6 important steps are mandatory. Number 1, high flow oxygen, unless the patient has COPD, okay? So oxygen administration, and to keep the oxygen saturation more than 94%. Number 2, take the blood culture. You do not go for, should not go for broad spectrum antibiotic before taking the culture. In that case, the culture sensitivity report will not be accurate, okay? So try to obtain the blood culture at least from 3 separate sites, okay? And send it, if possible, send it to 3 different laboratories as well. And go for broad spectrum intravenous antibiotics. Number 4 step, which is important, very important, because these patients are hemodynamically, they might develop septic shock. So that's why fluid balance is very important. We, in our country, we practice with 1 liter normal saline. In the NHS, they do not take risk like overhydrating the patients. So they go for 500 ml crystalloid solution, usually normal saline, but they start with a bit slow, 500 ml. And then we can repeat this after 15 minutes, like to check the patient's mean arterial pressure, because in already septic patients in their country, they go for the CV line right away. In our country, we do not really go for CV line that soon. And measure the serum lactate. This is an important prognostic marker. Number 6, urinary catheterization to maintain the urine fluid intake output chart. Or you can also, this is easier that way to maintain the urine output chart. Catheter is not advisable in all patients because it particularly makes the patient prone to developing further infection related to the catheter line as well. But if you follow the sterile techniques and the patient is already under antibiotic coverage, that becomes a bit easier to monitor the fluid intake and output chart. Okay. Lactate is for the prognostic, like serum lactate, LDH. These are all acute phase reactants. So more the chances of sepsis and multi-organ failure, higher the lactate level will be. And if the lactate level is more than or equal to 2 nanomole per liter, in that case, the patient will be having MODS or multiple organ dysfunction or failure in a very short period of time. This is within the red flag criteria. The red flag criteria, you can see if the lactate is more than or equal to 2 millimole per liter, this is considered to be in the septic shock leading to MODS. Okay, in the streptococci, this is further divided into alpha and beta hemolytic types. Alpha hemolytic streptococci, important is community acquired pneumonia, meningitis, and otitis media. Okay, and Streptococcus viridans causes infective endocarditis. Beta hemolytic streptococci, this causes complete hemolysis. Further, this is divided into A, B, D. Important is A, B, so A. Most important organism is Streptococcus pyogenes. Pyogenes is responsible for erysipelas, impetigo, cellulitis, type 2 necrotizing fasciitis, pharyngitis, tonsillitis. And after this sore throat episode, there might be some immunological reactions. Type 2 hypersensitivity reaction occurs in rheumatic fever, and type 3 hypersensitivity reaction occurs in post-streptococcal glomerulonephritis. Erythrogenic toxins can cause scarlet fever. So basically, toxins from the Staphylococcus aureus can cause toxic shock syndrome, and toxins from the Streptococcus, especially the group B, beta hemolytic Streptococcus, it can cause scarlet fever. Group, group B, whatever I mentioned, group A, beta hemolytic. Group B, Streptococcus agalishii, this is an important neonatal cause for meningitis. Group D, plus minus Enterococcus. Anthrax. Anthrax is caused by Bacillus anthracis, which is a gram-positive rod. This is spread by infected carcasses. Just 15 days back, we saw a patient with anthrax in Dhaka Medical College. The patient was a migrant. He used to work in the Saudi Arabia, and he presented to us with a very big eschar. Okay, and whenever we see eschar, we think either of the two possibilities, especially from infective perspective. That is, it can be either tick typhus. Okay, this can be rickettsial fever, basically rickettsial fever, or it can be anthrax. Eschar is very pathognomic for these two infective causes. So basically causes painless black eschar, which is a cutaneous malignant pustule, but there is no pus. It just basically looks like a very big black dot. A bit feeling is like a bit scabby like, okay? Feels like that area has dried up, shriveled up, and kind of looks like a gangrenous type of lesion, but this is not technically gangrene, because gangrene will take place like in either the digits or the toes or the legs or whatever. But if this is a circumscribed like gangrenous type of lesion, this is a very well circumscribed area. Okay, that is eschar. This is painless, non-tender, may cause marked edema. So the surrounding area can be having edema, and anthrax can cause gastrointestinal bleeding. And treatment is ciprofloxacin. Brucellosis. Brucellosis in MRCP examination, there might be some clues. For example, this is a common infection in Middle Eastern regions and farmers. So occupation, look for the occupation. If this is a sheep handler, farmer, or like has any relation to do with farming, like drinking unpasteurized dairy product, okay, in that case brucellosis can commonly take place. Another infection, viral infection we have just read, that is commonly present in the sheep handlers. What is that? ORF, yes, but ORF is not really MRCP hot topic, brucellosis is. Okay, so brucellosis has an incubation period of 2 to 6 weeks, so it usually takes a little bit of time. Non-specifically fever, malaise, hepatosplenomegaly, okay, hepatosplenomegaly is a pathognomic feature, and sacroiliitis. Sacroiliitis or infective discitis, there are three important infection that causes infective discitis or sacroiliitis. There are other causes like inflammatory causes, like in ankylosing spondylitis or the seronegative arthropathies, sacroiliitis can take place, right? But from infective causes are, number one is tuberculosis, number two is Staph aureus, and number three is brucellosis. Complications, it can cause invasive bone infection like osteomyelitis, infective endocarditis, meningoencephalitis, blah, blah, blah. Here, diagnostic purpose, brucella serology is the treatment confirmatory test, because if you go for the blood and the bone marrow culture, it is not really, not always positive. So your investigation should be brucella serology, okay? Treatment is doxycycline and streptomycin. Remember doxycycline. Tuberculosis, I think I don't have to read about this much. I will just ask you, like in anti-TB regimen, how many months? Pulmonary tuberculosis? 6 months. Initially, how many months? 2 months, and then 4 months. So initially in 2 months, what medications we go for? 4 FDC, right? What are those medication? Ethambutol. And in the later 4 months, which 2 drugs are given? 2-FDC, rifampicin and isoniazid. Okay. In latent tuberculosis, okay, so what's the treatment, what's the investigation modality? Latent TB to diagnose? IGRA test, okay. This is the gamma interferon release assay, IGRA test, but this is done in our country's perspective. But in the UK, they still go for MT test, okay, Mortis test to diagnose latent tuberculosis. So if, for example, if somebody has been tested positive for latent TB, in that case, treatment is required or not? Required. So what's the treatment modality?
Isoniazid.
Isoniazid for 6 months, or isoniazid rifampicin for 3 months. Okay, either of these 2 regimen is acceptable. Okay, meningeal tuberculosis or extrapulmonary tuberculosis, what's the treatment protocol? 12 months anti-TB along with the steroid. Pleural tuberculosis, like for example, in TB patient, you are getting pleural effusion. Is it pulmonary or extrapulmonary?
Pulmonary.
No, it's extrapulmonary, okay? Because pulmonary means in the lung parenchyma, and when the pleura is involved, in that case, this is extrapulmonary.
Extra. Thank you, ma'am.
Yes, no problem. And let's see, directly observed therapy. This is part, in our country, we have to make sure that each of the patients receives tuberculosis. As I have, like back in my Upazila Health Complex, this is a common thing. We do have a DOT center, okay? In every Upazila Health Complex or the tertiary hospital or the secondary health complexes, DOTS therapy is a must essential. You have no idea how much our government is spending money on TB projects, because the tuberculosis is such a prevalent condition in Bangladesh. But in the UK, they do not offer the DOTS therapy commonly for everybody. So people who are homeless or for like living in the prison, or maybe who are poor compliance, in that case, they go for the directly observed therapy, okay? Okay, side effect. So what are the common side effects of rifampicin? Start from like less severe first. Red or orange discoloration of the bodily secretion, okay? This is not something to be concerned about, it can happen, okay? And apart from that, remember all the anti-TB medication will cause hepatitis, okay? And rifampicin can also sometimes cause GIT upset as well. And what's the important complication related to isoniazid? In order to prevent that, what medication we go for? Pyridoxine, which is vitamin B, B6, okay. And what's the commonest complication of ethambutol? Optic retrobulbar optic neuritis, okay. So that's why visual acuity should be checked before starting the ethambutol medication. And what's the common complication of pyrazinamide?
Gout.
Yes, gout and hepatitis, yes. Okay, apart from that, streptomycin, that is also sometimes used, right? So streptomycin, what's the common complication? Ototoxicity, nephrotoxicity. Is ototoxicity related to macrolide antibiotic reversible? No, it's irreversible. Okay, tuberculosis screening, we have discussed this. Monto test is done. So interpretation of Monto test, you can give it a read. Like if it is more than 15 millimeter, in that case, we think that this is strongly positive, okay? Suggestive of tuberculosis infection. But if this is less than 6 millimeter, it's usually negative, non-significant. In that case, we can offer BCG vaccination. But if it is within 6 to 15 millimeter, this means that this is hypersensitive to the tuberculin protein, yet not 100% sure. So in this diagnostic dilemma, we can offer the patient IGRA test or the gamma immunoglobulin release, gamma interferon release assay test. False negative empty test, miliary tuberculosis, sarcoidosis, HIV, lymphoma, very young age. Just remember, you know, like in all this perspective where there is huge immunosuppression, in that case, cell-mediated immunity will not take place because empty test is nothing but cell-mediated immunity. Okay, so in severely immunocompromised patient, the empty test will be negative. HIV test is not done nowadays. It's just very much like the Monto test, just the concentration is different. Leprosy, okay, this is caused by Mycobacterium leprae. It causes granulomatous disease, primarily affecting the skin and the peripheral nerve. So long-standing leprosy can cause peripheral sensorimotor neuropathy. Okay, features are hypopigmented skin patches, and those patches are numb usually, okay? And sensory loss, okay? The degree of cell-mediated immunity determines the type of leprosy a patient will develop. So that means, what does that mean? That means the leprosy, we know that there are two basic types. One is multibacillary and the other one is paucibacillary. Multibacillary, that means within single ml of the blood, there is more number of bacilli, okay? Paucibacillary, that is usually one. Also, not the number of organism, but at the same time, in multibacillary, there is more hypopigmented patches. But in case of the paucibacillary, there is one hypopigmented patches. So obviously, in the multibacillary, the involvement will be more, like peripheral sensorimotor neuropathy is a common presentation here. But in case of the paucibacillary, maybe a single nerve may be involved, or maybe mononeuritis multiplex can take place. So if a person whose cell-mediated immunity is low grade, in that case, which one will happen? Multibacillary. But if it is a high grade cell-mediated immunity, that means my immunity level is good. So in that case, paucibacillary will take place. Treatment is basically triple therapy: rifampicin, dapsone, and clofazimine. Meningitis, according to different age group, the name of the organism will be different. Important one is neonatal period. Group B, streptococcus, which is the Streptococcus agalactiae, right? And E. coli and Listeria monocytogenes. This is the common cause of 0 to 3 months or neonatal meningitis. And in case of immunosuppressed patient, Listeria monocytogenes. CSF analysis, I think you guys know this better than I do. So I'm going to skip this. Meningococcal septicemia. What are the investigation you would like to do? Let's ask somebody from here. Dr. Laila Sharmin, are you here? Dr. Ahmed Sami. Dr. Ahmed Sami. Okay, Dr. Sami Ahmed, are these same people? I don't know. Okay, Dr. Elizabeth Sharkar.
Yes, please.
Yes, so in your medical practice or clinical practice, if you suspect that this person is having meningitis or meningococcal septicemia, right? In that case, what are the investigations you would like to go for?
CSF study.
CSF study, okay, yes, good, because we know that in all cases of meningitis, this is the diagnostic clue. But in case of the meningococcal septicemia, when you are suspecting the patient has, for example, the patient not only has fever, rash, fever, neck stiffness or photophobia, the patient has developed widespread skin rashes, meningococcal septicemia related rash. So it usually indicative of there is spread in the blood. And these patients are more likely to develop DIC or disseminated intravascular coagulation. In that case, you have to go for the CT scan first to rule out if there is any bleeding going on inside the brain. And after ruling that out, after treating the patient preliminarily, then you can go for the lumbar puncture test, okay? Because if you go for the LP test initially, there is risk of uncal herniation or DIC complication. Okay, let's see, meningitis management. So meningitis management is quite straightforward. IV ceftriaxone, right, in any hospital setting. But if this person has been having, like, for example, loss of consciousness, fell to the ground, and now the patient is being taken to the hospital, the patient has not already reached hospital yet, okay, but this is a highly suspected case of meningococcal rash or meningitis. In that case, the paramedics have the right to administer 1 ampule of intramuscular benzyl penicillin. This is the pre-hospital setup management. And once the patient has reached the hospital, in that case, IV ceftriaxone, okay? Because sometimes there will be some question scenario where both IV ceftriaxone and IV intramuscular benzyl penicillin will be mentioned. But your answer should be depending on the stem, okay? Okay, prophylaxis. If a person who has been in close contact with meningococcal meningitis, in that case, in patients who have been in direct contact within the last 7 to 14 days, we can go for prophylactic medication, either in the form of rifampicin or ciprofloxacin. Ciprofloxacin is better than rifampicin because it's usually single dose. CSF study, this one is particularly important in conditions where there is lymphocyte count is raised, like viral meningitis, tuberculosis, partially treated bacterial meningitis, Lyme's disease. This is also a spirochete infection, right? Becker's disease, SLE, lymphoma, leukemia. These are the non-infective causes. Acute epiglottitis. We have read about this in the ENT, right? What does it cause? This is more likely to occur in children. And which virus causes it? Influenza virus. What's the presentation like? Fever. Of course, epiglottitis will cause fever and drooling of the saliva. Okay, and stridor. This presents as like wheezy or noisy chest. So rapid onset, high grade temperature, stridor, drooling of the saliva, these are features or presentation of acute epiglottitis. In this case, if there is evidence of stridor, there is 100% indication of mechanical ventilation, okay? Or at least in the temporary time being, go for a tracheostomy. We have read some indications related to tracheostomy, right? Like foreign body impaction, laryngeal spasm or edema. This is epiglottitis, another indication for tracheostomy. Diphtheria, okay, maybe one star topic. This is Corynebacterium diphtheriae. This is a gram-positive rod, okay? It releases an exotoxin produced by the beta prophage, not really important. Diphtheria toxin commonly causes diphtheria membrane on the tonsil. So it's kind of like a whitish membrane, or like it looks like kind of like curtain looking structure over the tonsil or the oropharyngeal like junction, and caused by the necrotic mucosal cell. Systemic distribution may produce necrosis of the, particularly this can affect the heart. So cardiac arrhythmia or heart block, these are devastating complication related to diphtheria. Here you can see possible presentation, recent visitors to Eastern Europe, Russia or Asia. Sore throat with a diphtheric membrane, this is pathognomic, okay? Bulky cervical lymphadenopathy, neuritis, so it can cause cranial nerve involvement. It can also present like motor neuropathy as well, and heart block is the devastating complication. Animal bite, we have discussed about that. Cellulitis, so how does a cellulitis patient present like? Dr. Sami, are you there? Dr. Laila Sharmin. Okay, Dr. Obhijit, how does a cellulitis patient present like? Yes, Dr. Laila Sharmin is.
Assalamu alaikum.
Walaikum assalam, yes. So can you tell me what are the presentation of cellulitis is?
Cellulitis, painful swelling.
Painful swelling, very good. Are you doing internship at this moment?
Sorry?
Where are you based at? Like which part of Bangladesh are you joining us from?
I'm joined from Joshua.
Joshua, okay, all right. So can you tell me, like painful swelling, this is a very good presentation of cellulitis. Apart from that, patients tend to be a bit more toxic. Like whenever we are dealing with unilateral leg swelling, we immediately think this is either of the two presentation. It can be cellulitis or deep vein thrombosis. Deep vein thrombosis patients are usually not toxic, or they are not having fever. But in case of cellulitis, there is systemic involvement. So there is fever, and there is painful swelling and erythema. So cellulitis leg kind of, there is some color changes in the cellulitic region. Okay, all right. Commonly, which group of patients are involved in cellulitis? Immunosuppressed, okay, fine. Diabetic patient, okay, they do have cellulitis quite more often, and especially if there is any recent intervention, like maybe 7 days back some joint fluid was aspirated and now the patient has presented with fever and painful leg swelling, okay? So you should immediately think this is a case of cellulitis. And if there is like some route of infection, for example, patient was walking on barefoot and there have been some foreign body which cut the sole of the feet, and now the patient presented with fever and painful leg swelling, okay? So these are characteristic features of cellulitis. Treatment is first line treatment. Which one? Fluclox. Any skin infection, first line treatment is always Fluclox. All right. Usually, what are the indications? This is for your own understanding. This will not come in the part 1 examination. But in which condition we go for IV antibiotic or admission? Eron class 3 or 4 cellulitis, this I have gone through. This classification is so vast and so unnecessary. Like in our country, I think this is a good practice. Like any patient with cellulitis, we just straight cut admit the patient. Because in immunocompromised patient, like especially in diabetic patient, there is a high risk of having septic shock from cellulitis, okay? So you never know whether after starting a patient with antibiotic, that patient is still not under, not without any danger. So you should not take any danger, just admit the patient with cellulitis. Severe or rapidly deteriorating cellulitis, for example, extensive areas involvement, very young, so under 1 year of age, or frail patient like elderly, immunocompromised, has significant lymphedema, so the swelling is goes above the level of knee. In that case, has facial cellulitis, because this can easily cause brain infection. Cerebral venous sinus, cavernous sinus thrombosis, these are very catastrophic events leading to any facial infection, okay? So they do need admission. Periorbital cellulitis, very, very bad. Some diabetic patient present with the first presentation in late onset diabetes can be periorbital cellulitis, very high mortality. Admission may not be necessary if the facilities and the expertise are available in the community to give intravenous antibiotic and monitor the person, which means this is not available in our country. So that's why we do not go for any risk. We just admit the patient with cellulitis. But in the UK, there is one specific body known as OPAD, outpatient based antibiotic treatment. This is what they do is like in patients who are not able to be admitted in the hospital, they can receive this IV antibiotic in their own home setting, and a district nurse will be sent from the GP to that person's area or house, and they will monitor the patient, check the vitals, and administer the IV antibiotic. Okay, but this is not really possible in our country. Pyogenic liver abscess, necrotizing fasciitis, this is caused by necrotizing fasciitis caused by Streptococcus pyogenes, right? Treatment is, if you're seeing that there is a collection of infection, like for example abscess, liver abscess, necrotizing fasciitis, important thing is to do is first drain that area and then go for antibiotic coverage. Okay, because if you go for antibiotics simultaneously without going for surgical intervention, there will be no resolution. At the same time, there is risk of forming antibioma. Okay, osteomyelitis, sickle cell anemia, which organism is responsible? Osteomyelitis, sickle cell anemia, important organism, which one? Staphylococcus aureus, was it? Salmonella, yes. Okay. Splenectomy, here I think lots of information is given in your book. These are mostly related to MRCS. For MRCP, focus on emergency splenectomy and elective splenectomy. Elective splenectomy is usually gone for patients who are suffering from any bleeding disorder like ITP, myeloproliferative disorder like myelofibrosis. In that case, there is a room for elective splenectomy. And emergency splenectomy occurs in mostly traumatic or accidental causes, or sometimes in splenic crisis like sickle cell crisis can cause autosequestration leading to splenic like automatic splenectomy. In that case, in emergency situation, of course, we cannot prep the patient enough. Okay, so we just go for, after the splenectomy, emergency splenectomy, we give the patient some vaccination advices. Medical alert bracelet is given, lifelong penicillin, and vaccinations are yearly flu, influenza vaccine, and 5-yearly pneumococcal vaccine. And immediately after the splenectomy, meningococcal vaccine is given to the patient as well. But in case of the elective splenectomy, we can start this vaccination 2 weeks or 14 days before the splenectomy takes place. Okay, but after the splenectomy, this is similar for the emergency splenectomy. Congenital infection, important ones are to remember is rubella, toxoplasmosis, cytomegalovirus. Which one I told you to remember regarding the cytomegalovirus congenital infection? Blueberry muffin skin lesion. Okay, in case of toxoplasmosis, anything related to brain like chorioretinitis, hydrocephalus, cerebral calcification. And rubella virus, important here and here, here and here. So that means sensorineural deafness, congenital cataract, glaucoma, and heart. Congenital heart defects like patent ductus arteriosus can take place if there is maternal rubella infection. In the UK, among all these congenital infections, cytomegalovirus is the most common. Hematological malignancy, Epstein-Barr virus. Okay, without seeing this, Dr. Kobir, tell me, what are the malignancies that are associated with Epstein-Barr virus? Yes, very good. And another form of lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma. Okay, and in HIV patient, it can cause? No, primary CNS lymphoma, right? Basically, most of the time Epstein-Barr virus will be causing lymphoma. And any non-malignant condition in HIV patient? Oral hairy leukoplakia. Yes. Good. No, good. You remembered a lot of things. Apart from that, human T-cell lymphotrophic virus type 1 causes adult T-cell leukemia or lymphoma. And HIV can sometimes be associated with high-grade B-cell lymphoma. So here you can see HTLV1 causes T-cell leukemia or lymphoma, and HIV1 causes B-cell lymphoma. Okay, be very careful. They will flip these two things. Among all the bacteria, no bacteria is really responsible for any malignancy apart from one, which is the Helicobacter pylori, causes peptic ulcer disease. In the long term, it can cause gastric maltoma or lymphoma. Among the protozoal infection, malaria has a propensity to cause Burkitt's lymphoma. This is actually, I would say, hematological malignancy associated with infection. This is a 5-star important topic, okay? So we are done with our infectious disease. The topics that I mentioned, like 1-star topic, 1-star important topic, just give it a reading for one time. No need to go for, like, if you're not able to cram all the information, no need to worry about this, because MRCP part 1 examination is not about testing your cramming power, okay? Their question stems will be guiding you towards the answer. No need to utilize your cramming power. Of course, you need to cram certain important information, but the questions are not really like the residency exam in Bangladesh, okay? So no need to worry about, oh, whether this is bacteriostatic or bactericidal, whether this is cell wall acting or whether this is protein inhibitor, nothing like that. Just be very flexible with your study, and infectious disease is actually one of the easiest topics from part 1 examination, where 14 marks you can secure. Now, I think Dr. Abhijit, you told me like geographical distribution, right? So I have gone through this. There isn't much, like it always depends on the stem, okay? But for example, first of all, you need to remember all the tropical countries, like Asian countries, okay, and the African countries, they have the highest amount of any infectious disease. Like in Bangladesh, India, if the patient is coming from Bangladesh, India, most likely this is you're dealing with a case of typhoid or tuberculosis, okay? So if this patient is from some tropical countries, you're probably dealing with like a Strongyloides starkeralis, okay? Especially if there is mention of Brazil and or cutaneous larva migrans. And if there is any mention of, like, for example, African region, okay, in that case, malaria, and it could be related to some viral infection like Zika virus. And it's actually very difficult because, and from the Eastern European, I think one disease that was mentioned is from the Eastern European region, or the Russia. Brucellosis, where is it more common? Middle Eastern country, okay. Anthrax, this is not really any geographical variation, but it is related to dealing with carcasses, like dead animals. If you're a sheep handler, if you're a like goat handler, and now you're presented with some skin or mouth rashes, in that case, ORF. But if it is a fever, hepatosplenomegaly, sheep handler, sacroiliitis, brucellosis, okay? So you see, the question pattern is not really related to particular geographic location. There is mixture of varieties, like what kind of occupation does the patient do, from where the patient is traveling from, whether the patient is an immigrant or always, like for example, an Indian person who has been brought up and raised in UK, of course that person will not be having tuberculosis, right? But if the person has traveled to India, then they do have risk of being contaminated with tuberculosis. If in your stem there is mention of Thailand or any countries where you can get exotic experiences, always think of HIV, okay? They do have this discrimination against Thailand, I don't know why, but there's lots of tattooing and sexual activities going on there, maybe that's why. So I think I'm going to start with my question answer session. Please try to participate from the, because in here, whoever are present in front of me, I can see your facial expression, I can understand whether you're understanding or not. but it's very difficult to understand the facial expression from people who are, online, taking the classes online. So that's why I request to the online participant to try to actively participate in this question answer session. So Doctor, we'll start with Dr. Elizabeth Sharkar.
Yes, miss.
Okay, can you read out the question number 1?
Yes, sure. A 42 years old businessman presents to general practice after returning from a trip to Thailand 4 weeks ago. With an ulcer on his penis, he has a prior history of treated syphilis. On examination, you note a non-painful chancre on the shaft of the penis. There is no penile discharge and no lymphadenopathy is noted. Which of the following tests are more likely to reflect a repeat infection with Treponema pallidum? Number A, enzyme immunoassay. B, Treponema pallidum hemagglutination assay. C, rapid plasma reagents. D,
chemiluminescence immunoassay.
immunoassay. And E, Treponema pallidum particle agglutination assay.
Yes. So before you give the answer, here I'm giving you some clues. Like for example, you see this is Thailand case, but not really. It has to be related with some sort of sexual infection. So this man had already a previous case of syphilis, which was treated. And now he has presented with another episode of syphilis. So in that case, which of the tests would be positive, okay, in a reinfection with syphilis?
Number B, TPHA, I think.
Okay, TPHA, all right. So here's the thing, previously when I was discussing about syphilis, I have mentioned like VDRL, among the VDRL and TPHA, usually the TPHA remains positive for lifelong, okay? So this will not indicate whether a repeat infection has taken place or not. In that case, you should go for cardiolipin based test, like VDRL is one of them, and the other one is rapid plasma reagent, okay? So that's why the answer will be C, rapid plasma reagent. Okay, do you understand that, Dr. Elizabeth Sharkar?
Yes, miss.
Okay, good. You'll be having another chance. So thank you for trying this. Dr. Kobir, question number 2. Read this out, please.
A 37-year-old worker presents to the emergency department with flu-like symptoms of diarrhea for the past 3 days. Since this morning, he was started to develop a headache and size of meningioma found on fingernail. Blood test show potassium is 4.1.
That's normal. Urea creatinine is raised, okay? Okay. What is the antibiotic treatment of choice? So first of all, tell me, which infection do you think this is? Okay, here you see, it's a 37-year-old sewer worker. Yes, you're good, right. You're thinking in the right track. Treatment of choice. Which one? No, it's a spirochete infection, right? So benzyl penicillin, right? Leptospirosis, right? It's a spirochete infection. So which one would be the treatment? Spirochete benzyl penicillin, okay? Most of the spirochete is benzyl penicillin. But in case of the, like syphilis, what we go for? Benzyl penicillin. Leptospirosis, benzyl penicillin. Lyme's disease, a bit different, doxycycline, okay? But I'm glad that you got the diagnosis first, like this is a leptospirosis. Even though there is mention of meningism, the work is very much suggestive. At the same time, there is involvement of the kidneys. So hepatorenal failure, acute presentation, do have high suspicion of leptospirosis. What's the other name for leptospirosis? Weil's disease, okay. All right, thank you. Dr. Laila Sharmin, were you present in the previous class?
Sorry, no, miss.
Okay, no problem. I think I will give you the next question because it's a bit tricky now. So Dr. Obhijit, this one, can you read this out? So first of all, tell me what type of case you are dealing with. Did you get the clue? On examination, read the last line. On examination, large erythematous rash. She has recently returned from a weekend away in Hampshire. So Hampshire is an area where there is lots of backpacking and all these things going on. Imagine that she was in a camping or hiking in forest-like area. What's the diagnosis? No, there is no, the question stems will not be always having very straight clues, you know. So this is Lyme's disease, right? This is a characteristic, like on examination, large erythematous rash is noted in the middle central punctum is seen. Central punctum basically means central clearing, okay? So sometimes you have to read the characteristic of the rash and then you'll be able to understand. So in case of Lyme's disease, okay? So now tell me, what's the, given the likely diagnosis, what's the most appropriate treatment? Here, that's the twist. This is a 31-year-old woman who's 26 weeks pregnant. In that case, you cannot go for doxycycline. So treatment is amoxicillin, okay? So I will tell you, like MRCP part 1 is not really that straightforward. Here, whatever I'm trying to deliver, this will be a bit straightforward, but this is your duty to understand and go through the question bank, because if you don't solve the question bank, no matter how much you study, you will never have your knowledge, you know, broaden. You will not be able to, like, trust me, if you just solve the reference book and then sit for the exam, I can assure you that you will fail. But if you just solve the question bank and the questions that is located in the lecture book sheet, then you'll be able to have full pass marks. So that's why always after, when I'm done with the like lecture, go back to your home, read the materials first, read the text first from the lecture book, and then try to solve the question in the back of the lecture book. After you're done with the lecture sheet properly from that particular topic, go through the question bank, okay? Nothing else is required. No other like this and that junk books, like all these important like Maghrabi notes and notes, Oxford Handbook of Clinical Medicine. Yes, those are important to enhance your knowledge. Sorry? Same, all these are almost same. But you have to pass this exam. Like right now, when you you know, fill in the form, when you fill in the form for the examination, you immediately are a candidate, okay? Think of it like that way. Like there will be plenty of time where you can sharpen your clinical knowledge or you know, like broaden your knowledge. But right now you are spending a lot of money to pass this exam. So you have to tackle that first, okay? All right, I think Dr. Sami, he has left. So it goes back to Dr. Elizabeth Shorker. Can you read this scenario?
Yes, miss. 27-year-old student presents to the GP with a 24-hour history of explosive diarrhea and vomiting. On further questioning, he has not noticed any blood in his stool, has no history of foreign travel. He tells you he has been eating rice kept warm in a rice cooker for several days. What is the likely pathogenic organism underlying his symptoms? Bacillus cereus, Campylobacter jejuni, Shigella flexneri, Norovirus, Staphylococcus aureus.
So which one do you think is the right answer? The clue is given in the right, like first of all, this is a non-bloody watery diarrhea, okay? And 24-hour history. So that means this is a very short period of time. Incubation period is very short. And there's further clue that this student is eating rice kept in warm in the rice cooker. So reheated rice, okay? So now,
Yes.
Dr. Elizabeth Shorkar, can you tell me which one is the organism? Okay, no problem. Bacillus cereus is the answer, right?
Yes.
Yes, because Campylobacter jejuni, it has a longer incubation period. At the same time, it causes bloody diarrhea. Shigella, bloody diarrhea. Norwalk virus, it causes watery diarrhea, but usually not related to the reheated rice. Staphylococcus aureus, more prominent vomiting rather than diarrhea. Okay. Doctor, let's see. Dr. Kobir, this is your question. It's a bit difficult. I'll help you, no problem.
The 30-year-old man was recently integrated from Israel who is diagnosed with infected water after sustaining the 4 centimeter resolution of the production of his dead cat. He works as a builder and sustained the resolution after cutting into cardboard box in the steady night. For examination, the wound was only there is no sign of a foreign body or neurovascular disease. He is referred to plastic for acquisition of the wound. Once knowing about his tetanus vaccination status, he has no idea but can remember getting some vaccination inside.
Okay. What is the most appropriate action with respect to tetanus? Okay, no problem. Basically, this person has had a cut injury, with a Stanley knife. So that means the object is not really that high risk, first of all, okay? And this is not a complex wound. This is a simple wound. And now he doesn't know about his immunization status, but he remembers that back in the childhood, he has had some form of immunization. All right, now what is the most appropriate action? Do you think D is appropriate? Do you think option D is appropriate? No action required at all? C, requires human tetanus immunoglobulin. Okay. Okay, B is the option actually, okay? B is the correct option because in case of, if this was a high risk wound, okay, in that case, we would have gone for active and passive immunization. It's either active immunization or active and passive both, but no need to go for passive immunization. Immunoglobulin is for passive immunization. So the patient already has cut injury. So why are you going for passive immunization, right? So C is immediately out of the window. D, we are not going to do anything. That's quite stupid because this is quite a large wound. So C and D is out. Requires tetanus vaccine and oral penicillin. No, because this is toxin mediated. So no role of antibiotic here. So E is also out. It's either A or B. Now, if this was a complicated wound, okay, and if the, if it was a crusty object that has caused him this, or there is a contact with the soil, or high risk contact, in that case we would have gone for active and passive immunization and complete the vaccine course at a later date. But this is a clean cut injury, not really that much happening at this moment. And it was a Stanley knife. Have you ever seen a Stanley knife? This is just like the box. This is kind of like, what is this? We usually open it like this. There's a anti-cutter, right? You have seen anti-cutter. This Stanley knife is that. This is another name for the anti-cutter. And in that case, just go for active immunization and repeat the course later date, okay? This was quite tricky, don't worry about this. Dr. Obhijit, can you take this? Question number 6. Got the, did you get the stem? Okay. What's the most appropriate action now? So your, okay, before you give the answer, your stem is related to Clostridium difficile infection, okay? She was having pneumonia, she was given broad spectrum IV antibiotic. Now she developed Clostridium difficile infection. She has been started with the medication oral metronidazole. 10 days have passed, but there is no symptomatic improvement. Her hemodynamic condition is stable at this moment. So in that case, what's the most appropriate treatment now? Which one? Option A or option B? No, this is a gut infection, okay? Clostridium difficile is a gut infection. So in that case, you should go for oral vancomycin for 14 days rather than IV vancomycin. But if this was a hemodynamically unstable condition, in that case, IV vancomycin plus metronidazole, oral metronidazole. Okay, no, this is not related to, yeah. Okay, Dr. Let's see how many of you are left. Dr. Laila Shamin, I think you can take this. This is quite straightforward.
Yes. A 20-year-old student presents complaining of multiple painful ulcer on the shaft of his penis. He tells you he has had a new sexual partner recently, but she has not reported any symptoms. He feels generally unwell and had tender enlarged inguinal lymph node bilaterally. He denies urethral discharge or dysuria. What is the most likely diagnosis? Herpes simplex.
Yes, very good. Because the ulcer and the lymph node both are tender. In that case, no doubt, this is a case of herpes simplex. And he has a contact source, okay? So contact exposure. So in that case, this is not Beckett's. Beckett's is a autoimmune condition. So it has nothing to do with infection. Syphilis causes painless ulcer, chancre, lymphogranuloma venerum, and Donovanis. What does it cause? Painful ulcer, but non-tender lymphadenopathy. Okay, all right, good. Let's see, who did the first one? Elizabeth Shorker, right? Dr. Elizabeth Shorker, question number 8.
A 30-year-old man presents to the genitourinary medicine clinic. He has been handled a sleep-off and ex-girlfriend starting. She has tested positive for chlamydia. He has slept with her 2 months ago. He has no symptom of note, in particular, no dysuria or discharge. What is the most appropriate management?
Very similar sounding kind of options. So which one do you think is the correct answer?
Of chlamydia testing and antibiotic treatment. Yes.
Yes, okay, very good. Because in the UK, as this is quite a prevalent condition, so there is no, you can just go for the testing and without the test positive or negative, start the treatment because it's just single dose of azithromycin, okay? And the person has a positive contact history. So no need to go for Wait and observe. Okay, good.
Yes.
So Dr. Kobi, question number 9. I think we'll just go through, like, how many questions have we prepared? Let me check. I actually tried to gather the complicated ones where a lot of thinking may be needed, especially for beginners. So maybe we'll just go as long as 15 questions, okay? Question number 9, right? Yeah. Dr. Kobi.
35-year-old man returns from holiday in Italy.
Mm-hmm.
He has a 10-year history of rectal bleeding and surgery to our pain.
Mm-hmm.
For examination, there is
Painful swelling of his right knee. Yes, because this is the commonest cause of septic arthritis in young population. And there is history suggestive of sexual exposure, rectal bleeding associated with lower back pain. What is this condition known as? Reactive arthritis. Reactive arthritis is not always Ritter syndrome. Okay, Ritter syndrome is a variety of the reactive arthritis, but reactive arthritis can take place also following any infection, sore throat, diarrheal illness, anything. Okay, question number 10, Dr. Abhijit. 31 year. Okay, I think this is a bit too easy for you. I will go with Dr. Dr. Laila Sharmin. Dr. Laila Sharmin, okay, let's see. Yeah. Can you read the question number 10, please? Okay, if she's not here, Dr. Elizabeth Sharkar, can you tell me which is the most likely diagnosis?
Yes, Miss, bacterial vaginosis.
Bacterial vaginosis, offensive fishy vaginal discharge. Okay, yes, very good. Right, because Trichomonas vaginalis, pruritus or itchiness is more common. Candida, card-like or cottage cheese-like discharge. Chlamydia, asymptomatic, most likely. Bacterial vaginosis, there is fishy odor. Okay, good. Okay, Dr. Abhijit. I think this will be, he is also febrile. So you're dealing with an asymptomatic dysuria, okay? ESBL. ESBL is a common organism present in the catheter site infection, okay? Now go through the other parameters. Platelet normal, WBC count normal, hemoglobin considered to be normal in case of 82-year-old who has been having, benign prostatic hyperplasia, whatever. Sodium, potassium, urea, creatinine, CRP, all these parameters are normal, okay? Now let's go to what would be the next step to manage his bacteriuria. Which one do you think is the answer? B. This is a case of, there is a difference between asymptomatic dysuria and uncomplicated UTI, okay? This is actually asymptomatic bacteriuria. You have seen all the parameters are normal. The patient is not having any sign symptoms. Urine looks clear. And the catheter has been inserted where we see ESBL. ESBL is quite a common organism found to be in the catheter sites, okay? So A is the option, okay? That's why I put this question, because A lot of you will be going for the B option because this is usually the trimethoprim the nitrofurantoin. For a short course, we go for uncomplicated UTI. But UTI means the patient will be having small amounts of symptom. Maybe not fever, but there will be some form of dysuria or whatever. But in the stem, this is mentioned, there is no dysuria. So this is actually a microbiological finding rather than symptomatic finding. So no need to go for any antibiotic, just ensure good hydration and monitor the symptoms, okay? All right, number 12, okay, yeah, this one is quite straightforward. So Dr. Kabir. This is to some hematoma, okay, good. So sometimes there will be some straightforward questions, okay? So do not hesitate, just go for this is like solid marks, okay? 37-year-old immigrant, yeah, let's see. Dr. Elizabeth Shorkar, can you take this?
Yes, miss. 37-year-old immigrant from Bolivia is admitted to the emergency department following a collapse. He is known to have a history of Chagas disease. Which one of the following complication of Chagas disease
Majority of mortality.
Mortality in affected patients. Myocarditis.
Yes, very good. Because in Chagas disease, two commonly organs are involved. One is heart and the other one is esophagus. And esophagus is not really like the mega esophagus or whatever mega colon. These are not, they can cause obstruction or maybe even perforation, but this is not the common or prevalent mortality cause. And also you can see the patient is presented following a collapse. So most likely the heart is related. So this is myocarditis, very good. Let's see, number 14. Okay. Number 14, Dr. Abhijit. Okay. Blood pressure, respiratory rate is bad. Oxygen saturation. Oxygen saturation is also reduced, okay? The patient is taking 15 liters of oxygen. Initial investigation, hemoglobin is low. Platelet low. WBC count high. Sodium is 140. Potassium is on the rise. Creatinine is also on the rise. Creatinine is high. Bilirubin 70, it's also high. Malarial film. Plasmodium falciparum species seen. 12% parasitemia, okay? Given the patient's condition, which treatment should be commenced? Yes, very good. Because what's the indication for exchange transfusion? More than 10% of the parasitemia. Okay, very good. This is our last question. So among the three of you, anybody is welcome to take this. Dr. Kabir. Okay.
The 28-year-old student is admitted out of hours to the infectious disease ward with suspected malaria, knowing that around Southeast Asia, malaria research arose in with the parasite 1.5% in low consider malaria, looks like malaria.
Okay, I understand that we haven't covered this topic. That's why, no worries, you don't have to give the right answer. Okay, next up.
On admission, the patient is systematically well in observation as follows.
Everything is fine, okay? Now read the second part.
Although being little aware of past admission, you are told to remove one and 2 hours later into a condition of saving time blood pressure.
So everything is basically deteriorating now, okay? Just within few hours, within a very short time. And what was the Plasmodium? Plasmodium knowlesi. Okay. Which of the following attributes make Plasmodium knowlesi infectious particularly dangerous? Hypnozoite is more likely to be associated with vivax and ovale, okay? So, and also hypnozoite formation, there will be a gap of some time. Then the patient will deteriorate. But within very short period of time, this has happened. Which one? Cytoadherence, okay, fine. Answer is short erythrocytic replication stage, okay? This is not something we have covered. That's why I didn't expect you to know this. But actually, if this was resistant to treatment, there would have been some mention of some form of antibiotic or some form of antimalarial has been started. Despite that, now the patient's symptoms is progressively worsening. In that case, we would have thought that this is resistance to treatment. Knowlesi, not really hypnozoite formation because vivax and ovale. Cytoadherence, this is the classical tendency of the falciparum malariae because that's why they invade the central nervous system. So slow growth leading to late presentation, this is not really related to any of the malarial parasite. Short erythrocyte replication stage, what happens in case of knowlesi, it affects the red blood cell, okay, because this is an intra-RBC organism, right? So, and the replication is happening so fast within the RBC that the RBCs break down within few hours after being infected, okay? That's why there is sudden deterioration, okay? That's why this is the right answer. Short erythrocytic replication stage. Do you understand the reasoning behind this? Okay. All right, so yeah, we are done with this. I also prepared another slide for you that was further 15 questions, but I don't think we have the time. But you're always, I would again tell you, just stick to the reference book, solve the questions in the back of the book, attend the past test question bank. No need to separately go for past medicine because past medicine questions are more or less very much similar to the ones given in the lecture sheet. And after you're done with your system, like for example, after you're done with the infectious disease, try to attend the exam that will be provided to you with the online e-learning platform, okay? That's how you'll know, you'll be able to assess your knowledge, like, okay, I'm done with the lecture sheet, I'm done with the question bank, now let's see how much can I memorize or how much can I apply my knowledge to the real exam-like scenario. Okay, don't be so stressed. Part 1 examination is quite easy. The pass mark, cutoff pass mark is quite, it's not really that high. It's not like out of 1,000 you have to have 540 is the pass mark, right? So it's not really that big a deal. Just 40 marks more than half marks. In MBBS level, I think we had to, like 60% was our pass mark. So best of luck. Anybody who is appearing for the October diet? No one? Okay. So when are you going for the diet 1 in 2024, right? What about you, say? Okay. Dr. Elizabeth Shocker, when you're planning to go for the part 1 examination?
Next year, ma'am.
Next year, first diet or second diet?
Maybe second.
Okay, okay, no worries. You still have a lot of time, but do not waste your time thinking that you have a lot of time. Try to be, like patient. At the same time, try to keep yourself updated with knowledge, okay? All right, thank you. I think I will put an end to our discussion. I won't be available for the next 5 classes because I have my dreaded PACES examination. So I'll be flying to India very soon. Just keep me in your prayers, and I wish all the very best to your preparation, okay? Thank you so much. Thank you.
Thank you.